Hi, I'm Dr. Aman Chugh. I'm an assistant professor at the University of Michigan, section of electrophysiology. We're coming to you today from Boston, Massachusetts, from the Heart Rhythm Society meeting. And today, on Thursday, May 10th, 2012, I have the pleasure of interviewing Dr. Carlos Murillo from Hamilton General Hospital in Hamilton, Canada. Dr. Murillo, thank you for being with us today. On behalf of the AFibProfessional.org clinical community, I would like to welcome you to the interview today. It's great to have you tell us about your recent study, radiofrequency ablation versus antiarrhythmic drugs as first-line therapy of symptomatic atrial fibrillation, the acronym of RAAFT-2, which is a randomized trial. So would you mind telling us a little bit about the study and what you found?
Yeah, sure. Thank you very much for having me here today. Well, this study is a randomized clinical trial in which we randomized patients that had paroxysmal atrial fibrillation, and they had actually a high density of atrial fibrillation. They had to have more than 4 episodes in the past 6 months or so that had been documented electrocardiographically. And these patients were naive, or in other words, they had not received any antiarrhythmic therapy before being randomized. So what we did is that we randomized, and actually it was in 5 countries. We did this in Canada, the United States, Germany, Italy, and the Czech Republic. And we had 127 patients were included in the study. So 66 were randomized to the ablation strategy, and 61 were randomized to the antiarrhythmic drug strategy, which the most frequent antiarrhythmic drug that was prescribed was flecainide, and then followed by propafenone. So the study is a study that followed the patients for 24 months, and we gave each patient a transtelephonic monitor, and they had to send recordings every 2 weeks throughout the 24 months, which is quite challenging, but we were able to get a pretty good compliance. So the main result, the main purpose of the trial, the primary outcome, was to determine whether ablation was superior than antiarrhythmic drugs in the time to the first recurrence of both symptomatic and asymptomatic atrial fibrillation and atrial flutter and other atrial tachyarrhythmias that we see post-ablation. The main result was that ablation was superior. There was about 72% of the patients on antiarrhythmic drug had a time to first recurrence between those 2 years of follow-up, compared to about 52% of the patients that were randomized to the ablation strategy. So in other words, there's a relative risk reduction of about almost 50% in the presentation of these. In addition to that primary outcome, all the other secondary outcomes that included recurrence of symptomatic atrial fibrillation was also a 50% reduction, and recurrence of atrial fib and atrial tachycardia and atrial flutter, similarly a 50% relative risk reduction. The other thing that we also showed with a special multiple frequency analysis, in other words, similar stuff that they do in patients that have epilepsy or asthma, when you have more than one crisis. So we looked at the effects of ablation or antiarrhythmic drugs, and this did show actually that ablation had a highly significant reduction in the frequency of episodes of atrial fibrillation, a 67% relative risk reduction. So overall, it's a quite good result. It also shows that, and we had a very low rate of crossovers. Only 7 patients in the ablation group received antiarrhythmic drugs. On the other hand, almost 50% of the patients that were assigned to the antiarrhythmic drugs after they failed ended up having an ablation. So this is really a study of one single ablation, because only less than 10% of the patients had a second ablation. So it's pretty good results showing the reality of ablation in a multi-center, multinational trial, in which the success rate in these patients that are early on but very symptomatic is 50% reduction in the manifestation of atrial fib, and a very significant reduction in the frequency of these episodes.
Well, that's very impressive results, and I think one of the strengths is the rigorous monitoring.
Yeah, we did have over 6,000 TTM recordings that were, every single recording was adjudicated by the adjudicators, so it was a lot of work. And we were able to have more than 85% of the patients had more than 75% of compliance, in other words, sending all the recordings every 2 weeks.
How do you think the results will impact our management of these patients with paroxysmal atrial fibrillation?
Well, I think that, the guidelines still do not recommend ablation as first-line therapy for patients with atrial fibrillation. Usually people start an antiarrhythmic drug or two, and after they have failed at least one drug, these patients receive the option for ablation. So I think that the impact here is that we do know that the earlier you intervene, you are going to prevent the progression of atrial fibrillation. The mean age of these patients was about 55 years, so these are younger patients with not a lot of structural heart disease, perfect candidates for a procedure that actually was very safe. We didn't have a lot of complications in doing the procedure. So probably what this means for the general cardiologist is that if you have a patient that has a high incidence of atrial fibrillation, probably offering an ablation first compared to any antiarrhythmic drug is a good option. It's safe and it's effective.
Would you like to comment on the referral centers? For example, not every center is adept, has the volume, the experience to do these complex procedures. So for the general cardiologist, seeing a young patient, 50-year-old, who's otherwise healthy, who has paroxysmal atrial fibrillation, and the patient doesn't want to try drugs. Now, should that patient be referred to a specialized center, or can that patient be taken care of locally as first-line therapy?
Yeah, I think that's an excellent question. We do know that centers, and we selected centers that had a high volume and a great experience doing ablation, because we do know that the results of the ablation are directly linked with the number of procedures and the experience the center has. So we strongly believe that these patients should be referred to a center that at least does over 200, 300 AF ablations a year, which would be more or less the cutoff where we think these patients will have derive a greater benefit.
No, I think that's an excellent point, because we don't know if these excellent results will be maintained or will be reproducible at less experienced centers.
That is true, and I think that what I do try to recommend people is that, try to get centers that have less experience to gain more experience before you go for a first-line therapy. And then if you have this kind of patient, send them to a center where you already know that they have a low rate of complications and have a high volume, which is going to ensure the quality and the effectiveness of the procedure.
Would you also comment on how this study is different than other similar studies that have been conducted in the past?
Yeah, most studies in AF ablation have compared patients that already had received antiarrhythmic drugs or had failed antiarrhythmic drugs. And there was a pilot RAAFT trial that Andrea Natale, who's the co-PI, did back in the days, that was published in JAMA, that showed also a sizable effect. So that's why we wanted to confirm this in a more multi-center trial. And there's a trial coming out from Scandinavia in which they looked at patients with paroxysmal atrial fibrillation that had not received any other medications and showed some similar results. And this was reported last year at the American Heart Meeting. So the difference is that these are patients that have very little structural heart disease. Their CHAD score, the mean CHAD score in these patients was only 0.5. So these patients are low-risk patients for stroke, but they're highly symptomatic, and they had not received antiarrhythmic drugs.
What do you think the next steps are based on the results of this outcome? For example, both from a study standpoint and also thinking large, for example, will this impact the guidelines? For example, if you are at a high volume center, should your patient be referred for catheter ablation as first-line therapy?
I think this study provides further support to do that, to provide your patients, look, there's now 2 studies that, we joined the MANTRA PAF and this study. It's over 400 patients that were randomized as first-line therapy, and the results are very consistent. So you can tell your patient, look, you're a young guy, you don't want to take medications. We do have a procedure that is safe, less than 3% complications, none life-threatening, and we will be able to get rid of most of your atrial fibrillation. I think it's important to tell people that, probably we don't cure atrial fibrillation completely. We do change the natural history, which is important for a person that's in his 50s not to be having to take antiarrhythmic drugs or anticoagulants, because most of these people are in the low risk end anyways. So I think it's going to have a significant impact, because there's a lot of patients that are younger that are not really interested or will not be compliant with antiarrhythmic drugs. And we do know that antiarrhythmic drugs have a short-lived action in the sense of controlling atrial fibrillation. So, And in addition, we also did show, and this is probably the first time a study shows that we really reduce very significantly the frequency of these episodes, which we do know from experimental models that atrial fibrillation begets atrial fibrillation. So we may be able to look, and we're looking at and analyzing this data of the progression of paroxysmal into persistent and more follow-up to see if this does have an impact.
Well, thank you, Dr. Murillo. I've learned a lot, and I think this will really benefit the AFib professional.org clinical community. So thank you once again.
Well, thank you very much for having me here today.